acute myeloid leukemia is an extremely complex disease at a genetic level and at a chromosomal level. Up till now, we've used chromosomes mostly to try to determine whether the patient should get a bone marrow transplant or whether they should go to consolidation chemotherapy for risk stratification. But with the introduction of the molecular tests, we now can have targeted therapies. So when I see a patient who's brand new, I have to look at the history of the patient. Do they have a history of myelodysplastic changes, a history of second treatment? Because then I might be using CPX351. I have to look to see if they have a genetic alteration of FLT3, because then I might be using a FLT3 inhibitor either up front, such as midostaurin, or we may want to think about it if it's in second line, some of the experimental agents. If they have an IDH mutation, we now have a drug for the IDH2, and we probably will soon have one for an IDH1. And then if the patient has a core binding factor, a common chromosome abnormality where patients actually typically do well, well, there may be a role for genituzumab oogzomycin, commonly known as Mylotarg. So each of the new drugs has a specific area where they really seem to be shining.